Okay, hello, hello. My name is Mathias I3h, and I'm very happy to introduce today's speaker, Antonio Estache, who most of you know. Antonio is a senior fellow at I3h. He's also a member of I3h here in ULB. He retired as a professor of economics, or he was retired because we have mandatory retirement. He was retired as a professor of economics at the Université Libre de Bruxelles, where he taught between 2008 and 2022, also advising governments and international organizations on public services regulation, privatization, environmental regulation, public sector management, and tax reforms. But prior to that, he spent 25 years at the World Bank from 82 to 2007, working on various dimensions of public sector reform, procurement, financing, regulation, and project evaluation. Now, Antonio has published extensively in those fields, and he's very active with I3h. Since he's publishing a lot. Example in recent years, efficiency versus distributional concerns in regulatory sandboxes with Claude Camp in the Journal of Economic Policy Reform 2025. The macroeconomic cost of energy policies, quasi-fiscal deficit in the Middle East and North Africa in 2024 energy economics with Daniel Camos and Hamid. Three, on the political economy of industrial, labor, and social reforms as complements, European Economic Review 2021 with Renaud Foucault. Mentoring migrants for labor market integration, policy insights from a survey of mentoring theory and practice with Lisa Bagnoli, World Bank Research Observer, and prioritization of surgery in cancer patients during the COVID-19 pandemic, lessons from a failed balancing act 2021, annals of surgery with Vincent Donquier, who works at the Erasmus Hospital, with Michel Goldman, and with Mr. or Miss Liberale. So Antonio has a broad view of public services, including in recent years, and partly thanks to I3h, I think, including in health economics. Of course, he's also publishing books, and I highly recommend Regulating Public Services, Bridging the Gap Between Theory and Practice, Cambridge University Press 2021, with Emmanuel Auriol and Claude Camp. And so Auriol Camp Estache is also known as ACE. And I'm not a poker player, but it's a very good card, which I really recommend. Huh? So anyway, today he will talk about a paper which has connection with the one with Vincent Donquier and Michel Goldman, Regulating Public Services, Managing Policymakers' Biases in Dealing with Uncertain Hospital Capacity Needs. And so we are very much looking forward to listening to you.
Thanks a lot for all the marketing. Hope it's done well. So this is an unusual view of policy making, I guess. You'll see why I got interested in this. The more I read about hospital capacity, the more I see that people are worried about it. We know that there are other risks. We know that the way it was being managed in most of the countries was problematic. We didn't have all the support maybe that we had. If any one of you guys, and I hope you don't have these problems, need to go to the hospital on a regular basis, you know that delays are quite long. And this is true in Spain, in Belgium, in France, in the UK. And I think when I look at the forecast, the demand forecast available on publication, academic publication, my sense is that there's an estimation of the timing of the impact of demographic, environmental, and technological evolution. I mean, there are long-term trends, but I think they're biased in many ways. And this is consistent with the fact that you have central rationing, as we'll discuss later. And all of this is a consequence of decisions which were inherited from the past. And there are plenty of explanations, plenty of good explanations. As usual, I mean, we don't have a single reason, but my sense is that one explanation may have been underestimated. What if there is a behavioral bias in the way people decide. What if this is not a technical issue? This is not, something that has to do with the standard health economics type of stuff. What if we had a problem of excess of optimism by decision makers? This is something that seems to be very concrete. And when I look at the evidence, and I will summarize the evidence in a few minutes, I think the answer is yes. But if it's yes, then as a policymaker, can you do something about that? Can you come up with a use of fiscal policies or any kinds of techniques that we use in economics, like health, life valuation, for instance, to try to change the incentives one way or another, right? So that's the main purpose of this presentation. I will talk about the standardized facts, about usual explanations, and I will try to look at the role of politicians and their biases, and we will see, depending on the country, it's being decided by politicians or by managers, right? So I'll talk about these two things.
Will you, because you mentioned COVID, of course, COVID was completely new. All of a sudden, a pandemic, huge needs of hospital capacity, or are you talking about aging and the fact that we have a lot of structural problems and, better ways to treat cancer, but maybe that takes more hospital capacity and so on. So
I'll talk about shocks.
Okay, but shocks. So we should think more COVID than cancer.
You should, yeah, but I don't think you should give up on thinking about cancer, because the evolution is quite dramatic. Also,
okay.
I think as technology improves, awareness of the risks are increasing, and then I'll talk about it in a few minutes. Okay, just be patient with me, and I'll get there. And so my concern is at the end, and I have a few policy questions which are not in the paper, but in the context of the seminar, I wanted to raise them. So the basic standardized facts when you look at the evidence, and again, this is me looking at the academic research and some of the policy-oriented research. We have a growing demand per capita in total. We have a slowly dropping supply, even if you have technological changes which are such that you don't need the hospitals as much because you have a higher turnover, for instance. We have staffing difficulties in all of the countries in which I go. You don't recruit people that easily for a bunch of reasons. But what's interesting is you have huge variance across countries. But it's not just about beds and staff and stuff like that. You also have issues of affordability, of financing choices, of management choices. So it's very difficult to come up with a single assessment of the reasons. You have a bunch of reasons, and each one of them the mix of each of these reasons actually is different for different types of countries, and within countries actually for different types of region or different types of hospitals. I've put an appendix for those of you who are curious about all the data that I went through as I was preparing for this thing. So the appendix is quite long, but it's just data. So what's the evidence of a problem? The most obvious one that people talk about is delays. So we do have a capacity problem, which explains in many ways the delays. And it's quite significant, and it varies a lot per specialty, it varies a lot per region, as I say, but it's there. And we have a growing concern for the déserts médicaux. You have lots of places where you don't have access to doctors, and people have to travel 100 kilometers, for instance, to be able to get specific treatments on even a generalist, actually, sometimes. And so this is quite interesting because it leads to problems of quality of service and increasing evidence and correlation with respect to mortality rates.
We have a question from Michel online.
Hello, Michel.
Yes, first of all, Antonio, I'm very sorry not to be able to be on site. This was, beyond my control. But could you go back to the previous slide? Yes, I would like to challenge when you say growing demand for use of hospital beds. Obviously, there was the COVID-19 crisis where this was obvious, but if you forget about this, I think the tendency now is to reduce the number of hospital beds, at least the use over a number of days or weeks. All hospitals also in Belgium, because of the reimbursement procedure, try to reduce as much as they can the duration of hospitalization. And actually, we see that, for example, Erasme Bordet, they have problems to fill the beds outside, obviously, the crisis situation.
Yeah, I don't think we can agree on this. I think your two comments are raised basically by the second and the third bullet. You're right. They're throwing down the supply. They're trying to have a much higher turnover. You have a lot of issues which are sort of very easily handled by management decisions. But when you look at a demand forecast, not the supply, when you look at a demand forecast with an aging population, with a changing technology, which are sort of demanding more frequent, more recurrent type of assessments and monitoring. I'm going through that personally. For instance, I mean, you have to have many more frequent needs there. And one of the reasons why you don't necessarily have a full occupancy of your hospital capacity is that you don't have the matching component, you don't have the staff, you don't have the resources. So you can't have a bed that is not attended by enough nurses. So there is an issue. I think it's a very complex issue. I don't want to talk too much about this in the presentation because this is not about the shock, which is what I really want to talk about. But the difference, the gap between demand and supply is something which I find quite well increasingly documented in health economics research. And as I said, there are plenty of reasons. One of the things that you mentioned was the price of care, and this is what I mentioned by affordability and finance decisions. All of those things interact in such a way that supply indeed will drop, but it doesn't tell us that demand will drop. Every study that I've seen that looks at long-term demand, and many of them I'm not confident about, but every one of the studies that I've seen that suggest that the trend is still quite increasing for a bunch of very good reasons, actually. In addition to the need to be able to anticipate and to decide the extent to which you want to take care of a possible shock. These are two different types of perspectives.
I don't want to make the discussion too long, but there is certainly a tendency when you talk about hospital beds, there is a tendency, especially for senior people, to drive them as rapidly as possible outside the hospital to, the EHPAD, for example, facilities. Yeah. So I think that there is also a tendency to use beds outside hospitals.
We agree, and I think in the paper I talk about that, not here, but in the paper I said indeed that you have some of the technology, some of the decisions which are it's cheaper to take care of them outside of the hospital. So you take them, so you fly them back or you drive them back to the hospital on a need basis, but you still need the hospital. So we'll come back if we have the time, but let me get to the most
okay. Thank you.
So we've already talked about these sort of issues. So when I'm looking for explanation, so this is part of the discussion that we have here. So again, when you read all these papers that talk about these sort of issues, you see that you have management problems, and these are some of the papers focus on sectors, some of the paper focus on hospital-specific situations, and obviously, I mean, management is such that people learn to live with the capacity constraints. And when you look at it, the way they start to live with it is you look at them. For instance, the number of mergers that take place, you look at the reallocation of patients across hospitals, you could look at better uses of technology, and then you see lots of techniques to invest in surge capacity. But all of them have their own limits. I mean, again, I go back to my trend, and I'm worried about the trend again. Financing problems, they're everywhere. They're everywhere right now. And part of the problem also is that people have a certain reluctance to contribute. I mean, we think of health as an entitlement. In Spain, for instance, when they tried to ask for €1 increase in the contribution to refinancing of medication, there was a very violent and aggressive protest related to that. It was €1. Demographic problems. We are getting younger. We have plenty of issues that come with that kind of stuff. And this is actually for Michel also. We have a growing preference for preventive monitoring versus curative treatments also, which also contributes to change to the evolution of demand, which is quite significant. And this combines with the fact that you have lots of people who don't want to be doctors, who don't want to be nurses, or if they want to be doctors, they want to be 9-to-5 doctors. I mean, these are the sort of issues that explain why there's a mismatch between supply and demand. So there are many, many reasons, but these are not the reasons I want to focus on. I want to focus on size and absolute and the decision-making process that leads to the choice of size. I think it's an understudied topic. I started looking at different countries. And for instance, in the case of Belgium, I looked at the public health emergency preparedness assessment for Belgium, since you guys are going to have a seminar on this. If you look at it, I mean, there's very little said about size, for instance. And I find many of the policy debates sort of focusing on very technical, very interesting issues, but they don't really talk about possible behavioral biases that may take place. Risk perceptions. I mean, if I look to Michel, if I listen to Matthias, if I listen to maybe some of your questions later, none of us actually, there is not a strong convergence of assessment of risk. We have different preferences, and that's it. And the way we manage these perceptions can be different, and we have different horizons. And this has some implications for those of you who do cost-benefit analysis. This turns out into a different rate of time preference and a different discount rate. So the value of some of the investment decisions that you can make are biased by your behavioral distortions. And that's the sort of issue that you will see in a minute. Now, these biases are part of life, of course, but why would you assume that healthcare specialists don't have these biases? Why do we assume that, no, lots of people don't have these biases? Most of the people making these decisions tend to be optimists and many maybe more pessimists, but there are clearly two types of groups with a continuum, really. But if you want to divide it into two groups, you have optimists and pessimists. And they're not necessarily the same decision. Conceptually, the way we think about these sort of issues, one way in which you can think about this is that an optimist will rely on what we call a maximax criteria decision. Look at all the possible situations and you pick the best among those situations. The pessimist will look at the maximum. They try to consider the best among all the possible bad situations, the worst situation. And you will see how this interacts. I will come back to this slide a number of times. So an optimist relies on maximax, a pessimist relies on maximum. And so what I try to come up with, I mean, what we try, because this is joint work with Omar Chisari in Buenos Aires, can this help explain difference in short-term investment decisions in health capacity? And I'm not the only one thinking about these sort of issues. When you look at the literature, and I try to look at who talks about optimism versus pessimism. Obviously, psychologists talk about it, right? This is something we should expect. And at the last survey, if you're interested by these two people, political science, you have evidence that more politically conservative individuals are more likely to be less concerned with risk. You know, in the US, actually, there are a series of papers which are quite interesting that show that according to the political color of the heads of, the governors, for instance, or the head of the health organizations, you can predict the kind of budgeting process or enforcement commitments that they will take care of. And that this was not actually greater for the crisis. And there are similar diagnostics now coming up for Europe, if you're interested, it's that and a bunch of them. So politicians have their biases, and they make a difference, obviously, to the way they implement the way they address the health concerns that people may have. Same stuff in behavioral economics, same stuff in cost-benefit analysis, and you do have surveys that look at these sort of issues. And within health economics, what I found useful also is that if you start looking at all the papers that look at what drives the size of the hospital capacity of a country, they put a lot of control variables, the way we call them in econometrics. They look at what could be influences. That you see things like legal biases, political factors are quite present as well. And this is the kind of stuff that sort of tells me that this may work. And these people, I think the three of them, Lindas and co-authors, have actually tested that in the case of Norway. And they tried to look at which decisions within the management of the hospital system can be explained by an excess of optimism or an excess of pessimism. Interesting paper. So how can I sort of come up with a more formal discussion rather than this was mostly an intuitive type of overview of the literature, but how can I come up with a more formal discussion? So I think of the problem as a basic trade-off for decision makers. One is dealing with the possibility of Russian services levels of quality in case of demand shocks, right? So I don't want to spend too much, and I'm willing to live with the social costs of not having enough capacity. That would be one way. Maybe because I have to minimize my fiscal cost. And the second option is that you live with a very fiscally costly excess capacity that will be only used in times of shocks, but that minimizes the social cost. I mean, these are the two main approaches that I can think of, and that's one way of modeling these things. And so the basic question that I want to deal with when I think about this trade-off is how much do behavioral biases drive the choice between these two options, and can I do something about it as a policymaker? Okay?
If I may, Michel's point about retirement homes as midpoints between sending back the person at home versus keeping the person at hospital, is that typically part of the grand strategy or not?
Depending on the country. When you have some countries where, again, that depends on how much you have a support system you have for the old people. I mean, if you look at Spain, for instance, you have a system that's very different across regions. The mortality rate of old people in Madrid is much higher than in some other parts of Spain because the resources allocated to this kind of stuff is very different. And Madrid was very effective at using old care, old people care locations as a substitute to hospital, which apparently explains part of the mortality rate.
But that's because of COVID, which was a specific disease. Again, I wouldn't think of, and of course now today we know pandemics can happen, but they are still very, very rare events. And on top of that, some kill young people, some kill old people, like COVID. Planning on something based on that, planning on hospital capacity on that, I don't know. I'm sure I would do that.
Then it's a good idea to leave the room now.
No, it's a question. I'm not saying that. My point is that the kind of disease I would think would be different, but
you have, as I said earlier, you have a large number of reasons why you need hospital capacity.
Okay.
Demographics is one of them.
Yeah.
The way demographics get implemented, you live longer, but the period of extended life that you get as compared to 10 years ago, you have many more diseases to take care of.
Indeed, yeah.
So there is, you have a multiplication of factors that people don't really look at. And as I say, I have health issues that I have to deal with, and I may have to wait until 8 months or 10 months between two appointments. In Spain, one of my cousins had to wait for 14 months after seeing the first appointment. But the situation is quite dramatic.
Indeed.
So a big picture vision of how we think about this formally. Again, this is more of an academic paper, so there is a formal model, and I'm not sure I need to get into the details of the model. So I did sort of a summary version of this story. So it's a basic micro sector optimization model of capacity choice under uncertainty, and a very specific type of uncertainty before you answer your question, and I'll explain this in a second why. And then we run a bunch of simulations to see how different types of solutions could be considered by policymakers to be able to get that. That's why, these are sort of simulation models which can be implemented in Excel. One of the reasons, and I'll mention that again later, but one of the reasons why I took this situation is because I used to work on infrastructure modeling, and we use this kind of technique actually a lot in infrastructure to be able to anticipate decisions, to try to simulate decision, or expose, and I'll say later to try to explain why we did the wrong choice. So in this model, we focus on decisions taken by two types of policymakers, an optimist and a pessimist. And I want to be able to use the model ex ante or ex post. Ex ante to be able to help guide decisions, to assess which policy will minimize the risk of biases in capacity decisions, and ex post to reconcile what I look at, and I try to find ways of minimizing the negative consequences that I may have sort of observed when I start analyzing the different drivers of the decision, including the behavioral driver. So this is what I'm interested in at this point. So the formal model looks like this. I'm trying to come up with a quantifiable measure of capacity, H, that will maximize social welfare for the country based on long-term healthcare needs delivered by hospitals. I assume that most health ministers have some sort of forecast of the long-term demand needs, which include the possibility of shocks. Okay. when you look at the empirical evidence, all the control variables are quite predictable, actually. And then in addition, you have some sort of a dimension for uncertainty. We have budgetary allocation, which in the context of this model is sort of a proxy for the minimum level of gross social benefit that you expect to get from a social welfare perspective from your investment. And so we first look at what would be this capacity in a certainty context, and then we look at how uncertainty will make a difference to the optimal choice. Okay. One of the things I'm going to talk a lot about is the relevance of operational and social costs in the choice. So it's not just about sort of deciding how much money I'm putting on the table. How much money I'm putting on the table depends on how I as a policymaker, value life, essentially, the social cost. And in standard cost benefit analysis, when you look at a road project, for instance, we look at the number of accidents that will be eliminated thanks to the fact that you're building a better road, for instance, or you do traffic management in a better way. The same sort of analysis can be done for any type of public policy decisions that involve public money. And of course, you have operational costs. I mean, you have to pay the salary of nurses, of the staff, I mean, of all dimensions in the hospital. So again, this is a model, right? This is not me sort of building up for reality and making a bunch of assumptions. That's what I'm maximizing. The budget allocation, I have the financial cost, and I have the social cost. And of course, I'm going to assume that, if I have no social costs, it doesn't make sense to have too many beds, right? That's my first assumption. So what does the social cost look like? If I don't have enough beds, I have to be able to put a number on the table when I make my decision. I know the social cost will increase with demand, and it will increase the size of demand, right? When I have a shock, it gets particularly worse. So I have to be able to represent that. Luckily, we have a quadratic form that helps to sort of model this kind of stuff explicitly. So if you don't want to look at the math, trust me, what I'm doing is simply doing the intuition, putting some equation on the intuition. Okay. So just, the C0 is the marginal social cost associated with the need to ration. And the C1 is the extent to which this marginal cost will grow with the number of patients increases. So when you have a crisis, C1 drives a brutal story, right? So when I do all the math, I come up with this kind of stuff. So the number of hospitals, what does this thing tell you? It tells you that I don't have to have a bed for everybody, right? And the driver of the difference is the cost. So as a policymaker, I need to be able to take into account explicitly not only the financial cost, but also the social cost. And when I do a simulation later, you will see how much of a difference this makes. They do matter a lot. So one of the reasons why you don't invest in full capacity is that it's too costly, which is implicitly what Michel Goldman was saying. It's not cheap to invest in capacity. So you may want to be careful, but you also have to manage a budget. And it has to answer Matthias' point. I mean, you can reinterpret the model. So the model is designed to think about capacity, but you can reinterpret the model. The math actually is very similar as a look at the need for additional capacity rather than simply capacity. Difference. I mean, it's the same variables that will come up, but the math will be more complicated. That's the only difference. So now becomes a question of uncertainty. We know now what the optimal size of the hospital system should be when I have full information, when I know everything about everything. But in real life, that doesn't happen. Here you have a subtle question, which comes back to your concern. I mean, you have a demand for things which are relatively predictable, which may be or not be well taken care of, like demographics and stuff like that. But you have also a demand that may result from shocks that you want to decide whether you want to take them into account or not. We focus in this paper on unpredictable demand. So this is not a case in which I can put probabilities here and there. I just don't know. Something could happen, but I don't know when and I don't know how much. So that's part of the challenge that we're facing in this real world, right? And in this case, any decision will be subjective, which is the point I was making earlier. We look at the health crisis. I think none of us in this room will look at the risk in the same way. So whoever decides to do the modeling will impose a vision of the world. It will be subjective somehow. So if I'm optimist, I will deal with it in one way. If I'm pessimist, I will deal with it with another way. So it's useful to try to compare how different types of individuals who make those decisions actually will make the decisions. There is some sort of psychological aspect in behavioral biases that may prevail in this decision. So this is what in economics they call a pure uncertainty with respect to demand. And there's a fair amount of views. I mean, the first paper that looked at this was a paper by Knight, which took a long time. It was in 1921. They took a long time to use it again. But if you look at, for instance, more recent stuff on financial crisis, Taleb, for instance, used the same type of modeling recently. So what can be done with dealing with pure uncertainty? The best thing we can do is to try to imagine things. What is the next COVID crisis? What can it look like? And I will mention a couple of people who think about these sort of issues these days. At best, the policymakers then can anticipate these shocks and try to imagine the importance of their impact. And then once we've done that, we can start assessing the gain and losses for each case based on my subjective vision of the world. And it's very interesting because you start to need to think about how biases actually make a difference to all of these dimensions that you're thinking of when you don't know really with a lot of details the kind of risk that you're facing. How would that happen? We go back to my basic type of decision making. The optimist will minimize possibility of bad news in favor of the possibility of good news, and the pessimist will actually do the opposite. So this cannot be the same decision-making process that takes place. Something has to be characterized to be able to see the difference and the impact of the differences in behavioral biases. And we can do this ex ante, actually quite nicely. And let me just show you how we do this. So I repeat, I cannot assign probabilities to any type of the scenarios that I can think of. I don't know when it's going to happen. I don't know how big it's going to be, but I need to think about the possibility that it's going to happen. And so that's why we need to think about different types of states of nature, basically. For the modeling purpose of this paper, we focus on three cases, three possible states of nature with respect to needs. We have no needs, 0. We need to take care of the whole population, N, or we need something in the middle, right? So how do we think about these sort of issues? Well, interesting, because how we're going to be dealing with it depends on a bunch of decisions. Again, to simplify the discussion, I'm focusing on the capacity needs. Antonio?
Yes, Michel had another question.
Hello again.
Antonio, I'm just wondering whether some people might be optimistic regarding some shocks supposed to happen and pessimistic for others. For example, some people might have, important concerns about pandemics and do not really consider other type of medical urgencies, such as, catastrophic situation. And also the needs of the hospitals are quite different. Did you take into consideration the different types of shock that you have to handle?
No, obviously you're right. I mean, you have different types of shocks, different types of concerns that you have to deal with, and each one of these different types will have different needs in terms of adjustment for capacity, staffing, and financing, and stuff like that. What we try to do is a simple model in which we focus on one type of shock, which is sort of a brutal random shock that can happen. So you're right. In the real world, I would have to do what you say. which means that I would have to have, basically I would have to end up having with some sort of a weighted average of the different types of shocks and what they do for the capacity needs. But this is just an academic exercise in which I'm trying to emphasize one dimension, which is the bias. But you're right, different shocks can be associated to different behavioral biases because people understand things differently according to the context in which you're analyzing the problem. You are right, but in this model, we won't do that. We won't do that.
Thank you.
So I have three states of nature that I'm considering, again, simplification. And so I need to think about three possible decisions also that I want to think of. So the first decision is that I decide that no one needs to get a hospital. And so I'm assuming that I'm no need to worry. The second one is that I think both patients who need a hospital will have one, but not everyone will need one. And the third one, by the way, if my shock is a lot more dramatic than what I expected, I may have some people who don't have hospital. And then my third case is that everyone actually will need a hospital as a result of my shock. So when I have these three possible states of nature in mind, and I need to think whether a policymaker is optimist or pessimist, I need to figure out a way of matching basically the three states of nature with the three possible decisions that can be taken, that can be considered, right? So I give up on the creation of hospital, which means decision one, I have H equal to 0. I'm installing some capacity H is equal to X, or I'm adopting a new full capacity strategy, H is equal to N. No, everybody in the population. So I'm starting with three states of nature, and I'm mixing them with three possible decisions. And I'm trying, in that matrix, I'm trying to figure out which one would be the one that's the more desirable, according to the bias that the individual decision makers have. All right?
You had said that without any uncertainty, even without any uncertainty, you did not want to have necessarily no rationing because there is a cost, of course. Here, you would have no rationing in the middle state under D2. So why not H a little bit below X?
I could have done that, but I chose to do it this way. I mean, I could have done it to be able to open, but it would have added information to the policy conclusion, but you will see some of what your concerns are come out of the simulations later.
Okay.
I just wanted to make the model simple, but maybe not as simple as it could be. But adding dimensions like the diversity of concerns and stuff like that would sort of make the message more difficult to go through. So we assume that the budgetary allocation is the main source of financing of the sector. We have two ways of allocating funds. You can decide to put the funds on the table ex ante, right? Or you can decide to sort of reimburse, basically, an ex post allocation to the services. And we look at the two possibilities, and we compute all the possible social welfare outcomes from all combinations of decisions and scenarios. Okay? So all combinations are being computed, and this is why I told you that Excel is my best friend, because I need to be able to compute all of these numbers. So I look at these, each one of those outcomes according to the fiscal rules, and that's what I'm assuming will drive the decision. But I need to explain to you how the decision will be taken once I've computed all these numbers. So remember that I told you that the optimist relies on the max decision rule, and the pessimist relies on the max-min rule. And in concrete, this is what it means. The decision maker, the optimist decision maker, will pick a capacity associated with the highest social welfare among all possible outcomes. Okay? The pessimist actually will take a different decision. He will take the maximum of all possible minima among the possible social welfare functions. I will give you an example in a few minutes that will make this clear. Let me just explain to you better. For those of you who want to read it, the example is easier. So we've computed all the possibilities of social welfare for each one of the combinations of decision and state of nature. Okay? And so what I'm trying to look at for the optimist is that for each one of the rows, for each one of the possible decisions, the optimist will always see the brightest light. So the highest social welfare will be Y. You see, I have costs that have to be considered. have a cost that has to be considered. So the optimist will always pick the highest number for each one of the rows. Also true. The pessimist will do the opposite. The pessimist will say, for each one of the possible decisions that I take, I'm going to have to deal with the worst possible outcome. And so in this case, the worst possible outcome is this guy. Right? And so that will drive basically the initial stage. Then the second stage of decision-making process is experimental maximin. So in this case, among all the bad news, I'm taking the news that is least bad. So this is my max among these three options. And this one, the maximum between these three options is what? So you already see from this very basic theoretical example that an optimist and a pessimist will not decide in the same way. And you also see that a key dimension is this kind of stuff. This example is an example for an ex-ante budget. So my main message on this one is that when I have an ex-ante budget, my decision is relatively clear. If I know all the variables, and again, in real life, when I do my financial model of these kind of decisions, actually I have an idea of the financial cost. I know how to deal them because I have data on this. And then I have a policy debate on what is the value of the social cost. There are different types of methods, and we need to agree on how this works. So my decision is quite clear in this case. Okay?
Yeah, if I may, because it goes a bit fast. And maybe I'm caricaturing, but okay, the optimist thinks everything will be fine, so you don't build any capacity, and that's okay. I don't think that's very interesting. If I may, the pessimist, I find that more intriguing because you're saying, even if I think the pandemic will hit for sure in a sense, so the whole population will be sick, I still want only to build capacity at a level X, which by the way is somewhere between 0 and M. We haven't said much about this. Why is it that, let's say, if X tends to 0, then the pessimists start looking like the optimists, which sounds frankly surprising.
No, not really, because we'll come back in this. When you see the numerical simulation, you will see that
the challenge you want.
No, you will see when I do the numerical simulation that the key drivers for your decision actually is not the budget or anything like that. In the movie, it's the specific values for these things.
Yeah, the cost.
I mean, I may decide not to cover the whole population because it's way too costly, and I'm willing to live with the social cost.
That will depend on X, R, and C,
Totally.
Or maybe only on.
No, it will depend on the whole population. It's a genetic equilibrium type of stuff. I mean, the interaction between these variables, you will see, give me a few moments and you will see the difference. And you will see that your intuition is not always right. That you can have a situation in which an optimist will be counterintuitive, totally counterintuitive.
From the model, I agree that.
All right, so now, so the first case was, I was thinking about an ex-ante budget, right? And on this case, I'm thinking about the reimbursement fee. That's becoming clear. In this case, actually, I cannot come up with a decision. Actually, I cannot come up with a decision. That's because these values are so incredibly important. I mean, when I'm comparing these things, right, which one is higher? Is my social cost so dramatic that it will be higher than my budget? If mortality rates are the consequence of a shock that have killed a very large share of the population, my social benefit actually is going to be negative. So this is the kind of situation that I need to deal with. So I know with an ex-ante budget what's going to happen. There's no chance, this is your interpretation, there's no chance an optimist will do anything with an ex-ante budget. All right? And there's a good chance that the pessimist will do something about it. That's what the model tells you. And again, it's not surprising, right? What's more interesting is that X is not necessarily equal to N, right? That's becoming interesting. But what's more interesting is that for the pessimist, the decision will depend on cost, social cost, and financial cost. So in real life, this makes sense, right? I mean, when you talk to the minister and say, how much are we going to spend on this stuff? You're going to look at the budget. You have a budget constraint you have to deal with. So I need to be able to compare all of these variables to the budget that I'm willing to put on the table externally. When I'm doing this stuff exposed, it's interesting. It's much less attractive. It's much less clear. But again, if you look at my table, I have plenty of question marks. So I need to be able to put a value on each one of these question marks. And this is why I don't see how I can sort of work without any type of simulation. The more complicated and more subtle point is that I need to be able to look at the extent to which the choice that are being made for these values is also influenced by the behavioral biases of the simulators. So this is another way, it's not just about the budget, right?
Excuse me. I just have a question about the table for the computer decisions. What is the thing that makes these decisions unclear? Is it because it's an ex post decision to make, or
no? Exactly what I'm doing. If you want to, for instance, if you want to do this kind of stuff, right? You just do an Excel spreadsheet. You decide what your social welfare function is, which basically is the budget you're willing to put on the table minus the costs which are being associated. So that's in your Excel spreadsheet, right? And then you do simulations on the values of the budget you're willing to put on the table, and you do simulations on what you think are the operational costs or what you think are the social costs. And any combination of these three dimensions will drive the optimal choice that you're looking for.
So I don't understand why in this second table we're not able to make to take any decisions based on this.
Because as I'm raised, my social cost is higher than the budget I'm willing to put on the table. If for a fiscal reason, my Y-X actually, genetic cost is very low, it may be actually low. So my social welfare function will be negative. You can have a negative social welfare function. Society can lose from the wrong decision.
Yeah.
Okay. So the punchline of this kind of stuff, right, is that I wanted to emphasize, and I'll come back to this again later because it's quite important, is that when you think about the information you get from this table, is the intuition is confirmed. Matthias' intuition is confirmed. An optimist and a pessimist will not deal with this kind of stuff in the same way. But if we sort of internalize the kind of decisions that we've seen, there is one budget rule that's better than another one, right? One of them will lead to no hospital in many cases. And one of them, H0, and another one will give us a chance of having a hospital. So there's a difference between the two, but I need to be able to understand the difference, the drivers of these decisions. The details matter. And the only way to come up with the details is to do the simulations for all possible combination of these variables. That's why when Michel wants to look at the different types of risks that people have to deal with, it's super important, with the number of variables that I have to deal with in my Excel spreadsheet explodes. So I have to be able to, so this is just a pedagogical exercise to show that behavioral biases matter. So how can my simulations help? Again, I go back to the same kind of the variables. These are the variables that I want, right? Remember? These are the variables that drive my decision-making process when I'm trying to think about what is the optimal capacity. They all are linked to my social welfare function. I need to put a value. We just put random values. We try to look at sort of to be able to do some simulations. In real life, you would have to take, you would have to get into the budget of the bank, of the hospitals and try to look at what the operational costs are. You have to look at things like that. And you would have to study the social cost benefit analysis, which have been done to look at what is the value of life. And for those of you interested, the last slides in the appendix, I just put randomly 6 or 7 different types of valuations of life. And you will see that they range brutally. What does that tell you? That tells you that you can manipulate basically the social cost. If I decide to have a low, if I don't want to do something, I can decide that the social cost is low. And how do I decide how can I come up with a low social cost? I use a methodology that allows me to have a low social cost.
Yeah, it was one of my discussions about what if we integrate the value of life into the equation and the impact on social costs. So we have to fix the value of life in order to be able to run the model, or
You have a discussion. Yeah, in real life, when we do a road project, just to do the comparison, there is a debate as to what is the value of life is. You do have a value. And so what we end up doing is that we can do doing simulations with a lower bound and upper bound. And if the two simulations give you the same decisions, you win. If the two simulations on the value of life give you different types of decisions, then you have a political debate. But you have to do simulations before you know whether you're fine or whether you have to have a discussion. Unless you have, that's why numbers, I mean, it's super cool to do the theory, but you will see that the numbers will tell you different things in a second, if you give me a second. So remember that if I have a formula for the certainty case, right? You remember this formula? So with the numbers that I use, I came up with a figure of 70. So I have a population of 100, n is equal to 100. I need to have 70% of the population with capacity of getting into a bed right away. And remember, this is a theoretical exercise. This is not a real country or anything like that. This is just to sort of illustrate a number of messages. So I'm going to be using this as a benchmark.
So without certainty, 30% of population is rational.
Right. Because I've chosen cost values which are such that I will have that. If you tell me that you want I'm your technician, right? And you're the minister. You can tell me, come up with the social cost that will be such that I get 100 or I get 0.
We're thinking more of the, then when you start having uncertainty, then H will not be equal to X,
No.
but X minus maybe 30%.
Yeah. Okay, so what I did is that I did all possible permutations, just to give you a sense. Okay, so I'm starting with the case of demand uncertainty. And the first case, I look at a low ex-ante budget. And in the second case, I look at the high ex-ante budget. And in this model, you see that, well, I'm going to go through this and then I'm going to show you that. Whether I have a high budget or a low budget, for the cost variables that I've chosen for these simulations to begin with, my optimist will never invest, and my pessimist will invest the equivalent of a certainty case.
Only.
All right?
What was the difference? Because I say V equals H. So, and H is what? Hospital capacity.
H is the capacity.
And V is the need.
And V is the demand.
Is the demand. But so then everybody's served there. And
No.
Not of course for the, I would have thought that you want, you never want to serve everybody. That was my question. But
We will see there are situations in which you do. Almost for a second. Let me look at all the simulations and then we can have this. Okay. And so now I'm looking at the same type of table with an exposed, low exposed, high exposed. So we have low ex-ante, low exposed, high ex-ante, high exposed. And you will see something which is quite puzzling. There is a combination of all of the variables that is such that I have no incentives to invest if I'm a pessimist. But in that kind of environment, my optimist will invest. So this is just to highlight the fact that the multiplicity of dimension is something that you need to be able to cater to. You cannot make ex-ante assumptions. You need to be able to put the numbers together at some point. And I will do a few more simulations in a second. But again, when my budget, and I'm going to come back to this in a second, but if my budget is low, the optimist will not invest. And the pessimist actually may invest for the variables that I have. Oddly enough, if my budget is high, it's not going to change anything to my optimist, but it may change something because these variables actually matter. So I need to understand why they matter. Okay? That's a story that's interesting. I mean, it's counterintuitive in some ways, right? Details matter. That's the main message, actually, that comes up with this stuff. So now I do what you wanted to do. I try to look at, for each one of the key variables, I try to look, for instance, at different types of dimensions. So my ex-ante budget, my ex-post budget. So I start with a low budget, and I look at all the possible combinations of the cost variables. And I get a story out of that. Then I do the same thing for the high budget, right? And what, I mean, for the low budget, for a high budget, what's the first thing that's striking? For an ex-ante budget, the optimist would never invest. It wouldn't be rational for the optimist to invest for an ex-ante budget. It's a bit more complicated for the pessimist, right? He will invest there, but there are cases where the pessimist cannot invest. So I need to be able to dig into the cost variables. So that's the interest of doing all this simulation, is that it allows you to identify the cases in which you need to be worried. If I look at this case, which is the worst case scenario if you want, if you're worried about risk, it's linked to high operating costs and low social costs. And you will see that in many of the simulations I'm doing later, right? This is the combination that is the most dramatic. If it's very expensive to run the hospital, and if you don't think the value of life is that important, why invest? So that could be seen as rational as well.
That's not surprising, let's say.
No, you're right. But again, if I'm looking exposed at this table, I'm trying to understand why there's no increase in capacity. I have a possible explanation. A possible explanation is that the decision makers are assuming that they're looking at the operating cost and they know they're high. But then the second variable is my social cost. Implicitly, they have an assumption that the social costs are low. Think of this as a reveal preference mechanism when you're doing an ex-post evaluation.
Can you just explain me why, in the case where we have a low operating cost and a high social cost, the optimistic will not invest? Can you show me the previous table, please? Because in the case where we have a high social cost, why wouldn't, especially in the case where...
You give me a more minute, I'm going to get to the social cost in a minute, the details. And if that's not your answer, we'll come back. Okay? So we have an interesting story that comes out again, and I can use it ex ante to try to tell people, hey, listen, we have to think about a different type of budget approach to what we're doing. We need to put the money ex ante or exposed. We need to put more money or less money. Okay, that's one way. But the other way is that we need to have a debate on the valuation of costs. So it's ex ante, this is useful, but I find it even more useful exposed, and I've done lots of auditing in my life of exposed situation. So this is the kind of model that you can be used to launch a policy debate for the future decisions. You guys have not invested, and this is maybe because you don't value life enough. Or maybe because operational costs that you're working with are not realistic, and that you need to think about other types of dimensions. So this is the exposed use of this kind of approach. And again, this is a Mickey Mouse model. It's a very simple model with a few variables, and Michel is right, I need to have more variables. Matthias is right, I need to think about different types of situations also. But at least you have the intuition that doing this kind of modeling that I have not found in the literature on healthcare, but you have this kind of modeling in my field, in infrastructure, actually this kind of issue that we can be used to. So that's the main message that probably you need to remember from this type of discussion, is that the optimist will not invest in new capacity, and the pessimist is quite keen to do so, but this is not surprising given everything that we've talked about right now. And it's only if the expected social costs are low and the operational costs are high, that the pessimist will not invest. So we've discussed about that, I don't need to repeat this.
By example, exposed rule, you mean that you have a given budget, which is your constraints?
Yeah.
Versus you can
reimbursement rule.
Okay, so
ex ante is that you have a budgetary allocation that's decided at the beginning of the year and you live with it, and the minister negotiates you have to given budget allocation. And the second approach is that you have a reimbursement. In real life, it's hybrid. I mean, they could put on the table, and if you have crisis, they put more money on the table. but how much more money they put as part of what this model tells you. So we've already talked about this. I don't need to go through this in more detail, but if we don't know the behavior bias, this is quite useful. But what I like about this kind of approach in policy circles is that if the minister wants to have a fair discussion, this kind of instruments can ex ante fuel the debate, can force a policy discussion and a political discussion on variables which tend to be underestimated and they're quite crucial. As I said, when we do project finance in infrastructure, we deal with this. We don't deal well with it, we do deal with it somehow. So I'm just surprised. And frankly, the few cases that I've looked at in the UK, which they use this type of model to decide on hospital capacity in the UK, many of the variables were there. It's just that they were biased in the choices that they were made. The demand is typically overemphasized. I mean, they're overestimated demand, and the costs are underemphasized. But the point is that the discussion that I want to have ex ante is politically complicated, right? Because how do you value life? You're going to have some economists get into the room and say, well, we have different types of techniques. Which one do you want to use? And if the decision maker is not sort of aware of these different types of approaches, you're going to have an issue there. Let me just take a few seconds to sort of develop a little bit what I think it tells us about the real world somehow. Most countries in Europe I can think of are dealing with budget constraints. So if you look at my tables, they're all going to be under the low budget assumption. We've established that an optimist will not invest, but for the pessimist, I really need to be able to look at all of the variables. If I do this expose to try to discuss what would I do better in the future from now on, given that I know that I have a number of possibilities that health shocks will arise, that I have a possibility that there is an increase in the demand that comes from sources that I may not have anticipated, but which are sort of related to age, technology, or things like that, right? These models are quite useful actually to help you think about variables that you need to think about. And very frankly, when I do these kind of models, most of the discussion is around the valuation principle. That's where it comes out. So let me look at the simulations, for instance, that you wanted to have those social costs, right? This is what you do. All the possible combinations that you have for different types of variables, depending on whether you assume that the social costs are higher or not. Even a pessimist might just will not invest in social costs in many cases. And why? Because my social welfare function. Because
Give me if look here, okay, I'm a pessimist, so I think there is quite a danger. We have a big pandemic. I will get a lot of money back, a high exposed reimbursement, and on top of that, building capacity is cheap. And still I don't invest, I don't understand it.
No, but I mean, again, it's a combination of values that I'm taking that make a difference. So you remember that these are about numbers that I've put together. So with the numbers that I've chosen, we did some of the simulation that can report.
No, because, so you're saying because I don't value life. But the optimist does value life and will in any case get reimbursed.
The optimist may value life. No, it does. Maybe.
No, but there are some cases
where
an optimist.
Yeah.
I'm trying to challenge you.
Yeah.
So I don't think I'm much more optimistic than the other guy. I don't think we'll have a pandemic. No, indeed, we don't care too much about building up stuff. Neither of us, because we'll be reimbursed anyway. Okay, it's cheap in any case. And we both I mean, when you say low social costs, I'm an optimist and I'm a pessimist, and we have both of them the same low value of life, and still the optimist may invest. I find that hard to understand.
The main difference between the two is that the optimist values a lot more the high budget. If you look at the simulations, the size of the budget makes a big difference to the optimist. It doesn't make as much of a difference to the pessimist. The pessimist is much more influenced by the social cost. Again, this is the way we model it, but that's the story that comes out of it. One size
That's
is
not
not
immediately clear from the slide, if I miss it.
But, sorry, if you look at high exposed, these are the only two cases. And remember the theoretical boxes, right? The combination, these are nonlinear combination of the variables. And the nonlinearity is what drives actually the outcome that you have. This is not a linear type of proposition.
Okay.
So it just confirms that the costs operating and social matter. But to my view, it sort of increases the transparency of the importance of the budget size, which is the point we just made right now. My favorite budget rule is an ex-post reimbursement, because I think I'm going to get more possibilities of getting an investment under an alternative modeling of the budget rule. Just to conclude the discussion on the operating costs and the simulations, we have, again, a story that comes out interesting. If my operating costs are very high, the optimist is not really interested in doing anything. And if the high operating costs are very high, the pessimist is only interested in doing something if the social costs are high. All of these are different presentations of the same type of data, right? So they make different types of points. What I find very more interesting is my variable effect. So I do have situation in which this combination of variables is such that an optimist may decide to invest when the pessimist may not invest.
But so if the economist wants to convince the government, we should come up with valuation method that value more the life.
Yeah.
So we will be biased towards this.
No, you let the politician decide. You say, I have different types of valuation of life. You decide which one you want. Ex ante, you increase transparency. You say these are variables that you need to think about, and these are the values that you can put depending on the method that you choose. Ex ante. Ex post, when I look at your choice, I can reconstruct the methods that you've used implicitly.
And based on that, I would just come up with the evaluation method that value life more for that. Because when we see that, they will invest only if they have a high social cost. So
you're right, but at the same time, remember that we have a fiscal constraint. And so if I have a budget which is high or low, we make a difference.
okay.
I have three variables I'm playing with all the time. Three variables that I have to deal with. And when you look at the papers that I've looked at in the academic publication, they tend to focus on one variable at a time. But it's the interaction between the variable that tells the story, the right story that explains. So this is, again, you can play with the model as much as you want, and I can send you an Excel version of the model if you want. So broadly speaking, my point is that I think that behavioral bias matter. And not just intuitively. They matter in a much more subtle way than we think, right? I think that I do have some leverage as a policymaker to try to think which variables I can play with. And the fiscal variable is certainly one of them. And social value of life is something that I can think of. It's more complicated for operational costs because depending on the country that you look at, you have some leverage for operational costs and some others you don't have. But it's a potential variable as well. And so the point is that unless you put the numbers together, I don't think you can make a fair decision. It's going to be a purely political decision. Eventually, it will always be a political decision, but you can make an informed political decision versus a non-informed political decision. That's maybe what you want to retain from this kind of stuff. And as I've already told you, this one exposes incredibly useful, for instance, for international organizations. I mean, the World Bank, for instance, that as an ex-post evaluation department, this is the kind of stuff that they do. Where did we go wrong? Why did we finance the wrong project? And these kind of models will also for hospital capacity at the country level, but it actually can be useful at the hospital level. So what I think I want to say a few words about is that the discussion we had at the beginning, the main interest from a sort of a governance point of view is that this kind of approach increases transparency of the decision-making process. And unless you have transparency, it's very difficult to achieve accountability. Accountability comes from transparency. And these kind of models help you increase transparency. That may be what you want to think about when you think about this kind of stuff. I think we've already talked about the fact that ex-ante evaluations are useful. I can run tons of simulations with whatever type of assumption the policymaker wants to play with. But that's sort of something, for instance, that in Belgium, the planning office could do. In some countries, it's the National Auditing Office, and sometimes you have other specialized offices. But this is the kind of model that can be used. As I said, I've used this kind of stuff a lot for 25 years in infrastructure. And then I'm still, I was in Senegal in November. And again, we talked about these sort of issues to try to make some new decisions in terms of investment, whether it's renewable or non-renewable, and stuff like that. This kind of stuff is useful, actually. Before I get to my punchlines, that I think not everybody will probably like. I don't know if you've seen this paper by the Center of Global Development in the US. It's quite interesting because it estimates that in any given year, there's 4.2 probability of a new type of pandemic. And by the way, Michel, if you look at their research, there are tons of papers that look at different types of health risks, which is very interesting. But what I find interesting is that they talked about a forecast. They say there's a 50% chance that another pandemic on the scale of COVID-19 will occur in the 25 years that followed 2021. So you do have some people who try to put some numbers on these issues, right? That sort of can fuel the policy debate as to whether we want to do something about these sort of issues or not. So the question is whether are we ready or not? Europe counts 24,000 hospitals, more or less, with about 2.3 million hospital beds. And as Michel was saying earlier, we have a decline of 8% between 2012 and 2022. And what's interesting, again, to highlight Michel's point, is that this data excludes changes in daycare, in hours of patient care, in lots of other things that are taking place. And Matthias, the growth of home and community-based care services, right? These sort of issues are not being picked up well by these makers, by the way. But what if there were some willingness to address a demand for other shocks politically? Well, first thing that I want to think about is that the reserves argument, it takes time to build. And I try to look at how much it takes. It does 3 to 5 years to have an average a new hospital thing together. But I don't see that on the agenda. I see lots of changes in management. I see changes in the organization of the sector. I see lots of things, but it was interesting that I didn't find many countries, except for 2, in which there is a commitment to try to increase the number of hospitals. And yet, as I said, we have demand. So my view is that optimists implicitly are driving the forecast, except in Ireland and Turkey. And in Ireland, if you look at the papers, it's quite interesting because they emphasize a lot of demographics and the evolution of the changes in needs by the old population and the multiplication of diseases that the old population is living longer are sort of exposing the hospital system to. So if the odds of random shocks grow, maybe we need a pessimistic minister in charge. If that assumption is realistic. Because right now, when you look at the evidence, and I do this for an ex post evaluation, all the simulations that I've done are consistent with the maximum view. When I look at the data and I cross it with my simulations, they're consistent with the boxes that are consistent with the maximum view. And so the last comment that I wanted to make is whether my advice is too much of an academic advice. The answer is yes, probably. Yes, but I want to recognize that we are part of the problem. How many of us would vote for somebody who tells us everything's going to be bad?
Trump said everything's going to be bad.
No,
He did it.
but he said to his people that everything was going to be good. So in a sense, I don't think much is going to be changing. The only thing that we can do as academics is to try to increase the transparency of the biases. This will not eliminate the biases, but it will certainly reduce some of the effects of these biases. I think there is a case to be a little bit pessimistic. Jean Rostand had this wonderful sentence. Ils sont très optimistes quant à l'avenir du pessimisme. I'm done, guys.
Thank
And
you.
ladies, of course.
Questions? More questions?
I just have a question about the model. You got the C1 on the denominator, but what do you
I
consider
didn't hear the first
the
question.
C1? You got that on the denominator, but why not on the numerator for a cumulative effect? Because the C0 for what?
Just the formula that you use actually relates to that. This is just a mathematical.
Okay. I thought it was a
It's
choice.
just a math stuff.
Okay.
We have a question from Michelle. Shit.
Yeah, first, and then Michel.
Okay.
Okay, so a question about modeling the optimist and the pessimist. Because you use the maximum and the max method, but in the literature that when people model the, for example, the risk aversion, they use kind of the S curve, utility function net to do this. And I'm wondering here that if the optimist and the pessimist are dependent on the risk level. For example, when the probability of something bad happen tomorrow is what?
To be able to deal with risk, I need to be able to come up with numbers and probabilities.
Yes.
In this case, I don't have probabilities.
Well,
The first paper that actually with specific probabilities was a 2023 paper on
Okay.
that I finished. And again, to sort of to link it to Michel's point is that I would have to have this kind of probability assessed for plenty of types of risk.
But you have kind of distribution of the
I have an implicit distribution, but it's totally subjective. That's the difference between your approach, which would be sort of analytically rigorous, but you have probabilities. Mine is I don't know, so I take 3 possible outcomes. I'm focusing on that.
well, you take the general probability distribution, with all the probability mass on one state.
That's a
Which is okay,
Yeah.
but it's okay, but you can also do some robustness analysis like
I could.
Christian suggests.
But I would need to have some data to begin with. Check. But I said the 2023 papers, if you guys are interested in that, look at CDG. They have several papers that look at these sort of issues the way you just look at them now. But they don't deal with behavioral biases. They take the average politician deciding.
Michelle had a question.
Ah non, ni on t'aide.
Qu'est-ce que tu as pessimiste?
Attends,
C'est pas
Okay.
bien affoulé.
okay.
Antonio, thank you so much for this beautiful talk and to make things understandable and accessible to non-economists. This was really a typical I3h exercise, I would say. 2 questions. First, don't you think that sometimes you might have conflicted views between the politician, let's say the health minister, and the hospital managers, who probably don't take so much into consideration the event of shocks, which is obviously a primary mission of the health minister. So hospital manager, at least in Belgium, might just try to reduce the capacity, and the health minister say, hey, look, we must be ready, and so we must have enough capacity in case of shocks. That's the first question. And the second, which is more or less related, to reduce the behavioral bias, do you think that artificial intelligence might be of help and to be able in a way to increase the number of parameters to be considered?
That's the next seminar, Michel. The next seminar, I'll tell you about the limits and the ethical behavior which is biased by intelligence artificial. Mais je vais revenir sur la première question. Let me get into the first question. I think you're totally right. At the beginning, we did the first version of the model in which the manager and the minister were different people. But it was making the modeling much less pedagogical, and so we decided to assume that we only had one decision maker. But everything we looked at is consistent with your concern. Actually, your concern is underestimating maybe part of the concerns. We have three individuals contributing to the decision-making process, at least. Maybe. So we have the minister, we have the manager of the hospital, and we have the doctors. And it's very difficult to get to a conversion between the three. And one of the attractiveness of this kind of modeling is that you sit with the three of them at the table, and you tell them, tell me what your assumptions are. You run the model, and then you come up with evidence on what the consequences of the assumptions are on the social welfare or whatever indicator that you want to rely on. This is the main interest of this kind of modeling. Again, let me go back to my sector, infrastructure. When we have this agreement between the state governor and the national government, for instance, and when the head of the head, for instance, of the transport agency that runs the roads or that runs the electricity system, we sit them in the same room. And people like me are there with an Excel spreadsheet. And what we do is that we listen to them, and then we run a simulation, then they have data that they can decide. And their negotiation is based on data, not on emotions.
Yeah, but one possible bias is that the health minister will try to have specialized hospitals in, for example, to deal with unexpected shocks, and leave the other hospitals outside the reasoning. And obviously, a hospital manager might not.
You're right. I mean, one of the simulations that we have not done, but that can be done, as I said earlier, one of the solutions they're looking at into the debate on capacity is to reorganize the sector, to specialize hospitals, as you just said right now. But this would require another type of modeling, which is possible. We would look at whether the social welfare function is better with merger or with reallocating within the hospitals. These simulations can be done.
That would be very interesting.
And the second question is about intelligence artificial intelligence. I think it's unavoidable. We're going to be stuck with it as a support to many management decisions. Probably somebody will put in the algorithm the kind of model that we've just discussed right now in a much fancier way. But whether the intelligence gives you, whether ChatGPT gives you the right answer or not, depends on how well the model was designed to, and how well ChatGPT understands that many of the results are driven by assumptions, and that assumptions need to be tested as well. So I'm not as optimistic as many people about artificial intelligence, and I'm really very curious about how, in the health sector, they're going to deal with the value of life. As you know, when you get into hospital, the triage, the way they decide who to take care of and who not to take care of, is a very sensitive decision. I haven't seen good modeling of that.
Well, I really fully agree with this limitation of AI. Some people will say that it will be overcome, but as yourself, I'm not convinced. Thank you so much again, and hope to see you in person soon.
Are there more questions or?
Curiosity related, but it's also for the experts. It's not very much model related. For Michelle and Matthias about the COVID experience, because one of the parameters that was crucial was the operational cost of running during a crisis. So given that you were in the unit, the emergency unit, after the experience, what is your sense? Was it a high or low operational cost? Because there were two elements. Now, the vaccination seemed to be very efficient. It was easy to set up these camps, and vaccination was fast. But emergency units, respiratory units were pretty expensive, no? So after the pandemic, what is your feeling? Was it very costly or
If Michel wants to go
easily
first.
scalable?
Oh, I don't have the precise figures. Obviously, there was several disruptions in the hospital functioning, so it was costly not only from a financial point of view, but to make the hospital making what they should do, and there have been many problems related to this. So the cost is also related to the care which could not be delivered on time because of the pandemic. So I think the cost was high, and I think that the lesson, as you mentioned, is that indeed vaccination was very important to implement as rapidly as possible, as we did well in all countries, but we were much less successful in low and middle income countries, which is a major issue.
Yeah, I agree that with all that Michel said. It's true that in the end, the for the policymakers, having hospital overload was in the end the biggest constraints that led to these non-pharma intervention, all these measures with the lockdown and so on, which is costly economically. But I think it was very, very important the view there was that the social cost was so important. And in fact, interestingly, if the virus circulates a lot, even if you don't do lockdown, people don't go out of their homes anymore. And so in any case, you have the economy tanking. So I think that the social cost was quite high. Of course, one thing which is very hard to model is that you can indeed kind of reduce hospital capacity constraint by taking these non-pharma intervention in order to be able to slow down how many people come to be. But this is a cost, and therefore it's important to. But I do think, for example, pandemics are like forest fire. So the important thing is to stop them before it starts, very quickly after it starts, and therefore you don't need the hospital capacity because you avoid contamination.
Yeah.
Okay,
No,
so thanks a lot. Great presentation, and see you after the summer.
Thank you.
Or next webinar.
Thank you. Bye-bye.
Bye-bye.
Merci Michel, bonne journée.